Action.
We're back for yet another beautiful videography session by Jenny. Today we're going to be talking about anesthesia. We're here with Daphne again. Say hi.
Hello.
Oh, look at you talk to the camera. You're already warming up. This is good. All right. So when we look at anesthetics, kind of how the setup goes, this is your syringe. This is how every dental syringe is. Some of them have the wing. Some of them have this on the back. I have massive hands, so I like to have the like this. Okay. A couple things about them. All of these are what are called aspirating syringes. Means you can pull back on them. And it allows you to kind of suck up when you're inside the patient to see if there's any blood, because you don't want to be injecting into an artery or a vein or anything like that. And the way that we make it so that it does do that is when you place it inside here, how you're going to place the syringe, because this is actually important. You want to pull back like this and then drop it in like that. Now, the other set of syringes we have here, these are very dumb and I need to just get rid of them, unfortunately. But they don't have quite as much space, so it's a little harder to get inside here, especially if there's already a needle. So what you need to do with these is when you pull back, you actually go in and push it, break the needle, and then go in like that. I'll show you in a second. Once the needles are on, this will make a lot more sense, okay? As far as the different anesthetics, we have 5 total different anesthetics that we're going to use. Pretty much these 3 are our main that I use on every single patient for different reasons. So the first one is going to be a lidocaine with it's a 2% solution, with 1 to 100,000 epinephrine. And what the epinephrine does is it helps hold the anesthetic in the area so that the anesthetic sticks around for a lot longer. They've done tests, and if you do the lidocaine without epinephrine, it'll keep the teeth numb for about 3 to 5 minutes, and that's about it, and then it wears off. With it, it's about 45 to an hour, so much, much better. This will always be my first injection. The reason we use it as the first injection is because it is very neutral as far as the pH. All of these are slightly acidic. Some of these are more acidic than others, and that's because to preserve the epinephrine, they need to keep it at a low pH. So most neutral. And this one you can also use the most out of all of them. The maximum amount of cartridges you can use on a single patient is the highest. That's why when you see Dr. Galea, the oral surgeon, he'll just use these for like a full mouth case because he can give 13 of them on a single patient. And sometimes when you have to get the entire mouth numb with infections, you do have to use that many. So if you're out there and need to do a lot of injections, lidocaine is going to be your best. That's going to be the first injection. We'll talk about setting them up as well. Second injection on most of our start cases is going to be this blue, and they have a red stripe. The nice thing is, even if it's a generic brand name, different manufacturer, all of these have the same coloration. So all you need to do is look for the different colors. So red is going to be the first one every single time. The next one is blue. This is Marcaine or bupivacaine. It's a lower percentage, and it has a lower amount of epinephrine in it. The benefit here is that it is extremely long acting. So if you use this for a block, it's going to keep the tooth numb for about 6 to 8 hours. Now, it's always important to tell the patient this because they're not necessarily going to be aware. They usually go to their dentist. Not a lot of general dentists use these. You should be using it more because it's a fantastic drug. But they're not used to being numb for this long and they think something's wrong. So we always let them know you'll be numb for longer. We do that on purpose because it allows the patient to get a couple doses of ibuprofen or Tylenol on board and it blocks the pain. The reason a lot of people have pain 2 to 3 days after treatment is because they have these pro-inflammatory things that are made inside our brain that then go down there and actually make the pain worse. If you can block that pain signal from ever getting to the brain never produces it. And by taking the ibuprofen and Tylenol, it'll actually decrease the production of those pro-inflammatory factors locally. So when the anesthetic wears off, the brain doesn't actually feel it anymore. Does that make sense?
Yeah.
That is the method behind why we use this long-acting one. I know it seems crazy, but that is why, and we have much lower levels of post-operative pain because of this. The other thing that's really great about Marcaine or bupivacaine is that it is 2 times as potent as any other anesthetic that we have here, which means this stuff works. The downside is it takes about 10 minutes to kick in. Now, good news is lidocaine's really quick. It takes about 3 to 5 minutes to kick on board. Same thing with our third one here. So generally, I'm able to start the access. By the time we get every patient ready and all that, it's been roughly about 10 minutes. And so by the time I need it to kick in, it works. But if we were to use it as our sole anesthetic, it would take a long time to kick in, unfortunately. So that's the benefit with this. We don't ever do this as the first injection because the pH is like 2. It's really acidic and it burns. When you're giving an injection, the pain for the patient is twofold. Number one is the actual deposition of the solution, because if it's locked inside there, think about like when we inject in the roof of the mouth, there's no space there. So you are literally having to create the space and ripping the gum tissue off of the bone. That's why it hurts so much. The other thing is, how acidic is it? Are you injecting something that's neutral, more something like a lidocaine or the carbocaine, or are you injecting something super acidic that's going to burn no matter what? So just kind of it's important you know all these things, explain it to the patients. And then the third one that we use on pretty much every single patient is this guy right here. This is articaine or septicaine. It is a 4% solution. We use the silver one, which has the lower amounts of epinephrine. You get about 15 more minutes of working time with the gold septa, which has a 1 to 100. But we see enough medically compromised patients who have like that weird heart palpitation thing that it tends to be better to do without. Okay, so I use the benefit of this is that it penetrates bone really well. And I will use this pretty much next to every tooth because it'll penetrate through both the mandible or the maxilla. And especially on the maxilla, I don't want to give that palatal injection because it hurts. We want to have a good experience for patients. That is a bad experience. The cool thing is by doing these 3 injections and then doing the local of this one, I have to get that palatal injection maybe 10% of the time. And I can usually tell when it's going to be on someone my size because the bone's denser the bigger you get. Someone like you, tiny little female, is not going to have that problem. So those are the 3 injections that we use for every single start patient. Any questions there?
No.
Okay. When we finish a case, the only 2 that we're going to use are the lidocaine and the articaine. And that's because I don't plan on creating really much any inflammation when we finish a case. I'm not really, I'll check to see if I'm patent, but that tiny little bit out there isn't going to cause inflammation like the first time would. And so for the patient experience, they don't like being numb that long, and there's really no benefit, okay? Now, sometimes you'll see that I'll do it even for a finish if they're, say, going next door to get a crown done. And that way, they stay numb and don't have to get re-numb after. So those are our main 3 anesthetics. Any questions about those? Okay. We have 2 extra ones that we use every now and then. This one is called carbocaine or bupivacaine. This is a 3% solution, and it has no epinephrine in it whatsoever. The benefit of this is on a lot of our patients who are very sensitive to epinephrine, what you'll find is that palpation, that like really strong heart rate, they don't get it with this. What I have found though is I can use this as the first injection and then still use the 1 to 200 solutions, and they tend to not have it either. So if you have patients who come in and tell you that they're really sensitive to epinephrine and have that heart palpitation, try that technique. Use the carbocaine for the first block and then try the 1 to 200 solution. I'd say 95% of the time they don't have it whatsoever. It seems to be the lidocaine that causes the issue. So good fact there. And so we only use this on sensitive patients. I don't use it very often. These definitely expire before I use it. I'll go through a full bottle. And speaking of other things that expire before I go through a full bottle, this is the green lidocaine. So this stuff is still a 2% solution, but this time it has 1 to 50 epi, so twice as much epinephrine. And I'll use this for surgeries. What I'll do is actually go along and inject into the gum tissue. You'll see it blanch and get super white because it actually constricts all the blood vessels. And it makes it so that when I'm doing my surgery, the field's a lot cleaner because there's not as much bleeding from there. So we won't be doing too much of these. It's really important that you know these 3. Just know that these are options as well. Okay? Any questions there? Perfect. As far as the different syringes or the different tips, this will change here soon because I'm switching to all 25 gauge. But right now, we have 2 different tips. We have the blues, which are technically short, and we have the yellows, which are long. The yellows are a thicker gauge, so these are a 27 gauge needle. These are 30, all right? The reason that we use the 2 different ones is because it depends on what injection that I'm doing. So in general, to make it very easy for you, the only time I really need long needles mandibular molars. Okay. I can do pretty much everything else with the short. Sometimes for premolars on the mandible, I find it useful. Sometimes if I'm working on like multiple teeth on the bottom, I find it useful to do a full block. But most of the time, if you need to guess, this is your guy. Okay. We use the short for everything else because the only time I actually need the actual length of this is when I'm getting it way back here numb. This does not get this numb. This is not long enough to get the IA. This is, all right? So only for mandibular molars, everything else is for this, okay? What I want to show you here is how we place this when we, Jenny, I'm going to kill a needle for you, sorry.
Wasteful.
Generally, you have two different options. You can either put the cartridge in first and then put the needle in. This is going to be the safest because you have no risk of bending this. And when it goes in, you literally just screw it in like this. And that's that. That's all you got to do. We have a little capper where you put this in here. So then I can just put it back inside there. We can safely recap and not have to worry about needles. And then when you change it, here's the important thing. You want to pull down like this, and it should just drop out like that. Okay. When you put it back in, you're going to do this. It happens to everybody. Sometimes if you're not careful, you'll actually hit the needle with the metal like this, and nothing comes out. And that's because what we just did is we bent the needle back here. And if you look, oops, this was dead.
All of you ignore that recapping that he just did.
Well, it's sterile. Also show you another thing that can happen. Sometimes this happens. Yeah. Where it actually gets stuck in there. It's fine. It's sterile. If this gets stuck in here, you have to remove this. So when you're doing sterilization, you have to make sure that that's out of there because we don't want to push you don't want to push that through another one. But if you look inside there, you can actually see how the needle's bent. Yeah. You see that? I can really clearly show you when I unscrew it. That bend right there. That's what we want to avoid. And the way we do that is when we place it, you can see this, you can actually see the divot in the metal where it hit. See that little part right there? That's where we want to hit. So when you place it, what I recommend is to kind of feel it, and you'll actually feel that little bladder get pierced, then drop it, and then you can go in and you're good to go. Okay. For removing, just be careful when you unscrew these, especially if they're bent like this, because sometimes you can get yourself. Pretty much either unscrew it like that or twist and pull. I like to twist and pull, but either way works. So, but that's pretty much the local anesthetics. Any question as far as that? The final thing I wanted to talk about was topical. I probably should have started with this. So we use benzocaine. It works really, really well. It is mint flavored because all the rest of them are garbage. I tried all of them. They're terrible, especially cherry. I don't even know why they make them. Anyway, what you do, the important thing with benzocaine is that you dry the area with a 2x2, place that, and then we put the 2x2 on top of there because what that does is it stops any of this from going down their throat and then feeling that awful sensation. So that's pretty much, we use it on everybody just to make sure they have a good experience. But yeah, that's kind of your anesthetics. So we'll be in charge of these from here on out. Cool. Thanks, guys.